Hello everyone, hope you're all doing good. In this video, we are going to discuss about urinary incontinence. Urinary incontinence is nothing but the involuntary leakage of urine. Okay? So, there are different types of urine incontinence. It can occur at the level of urethra, where it can be known as stress incontinence or urge incontinence, or else both the conditions can be mixed together, that is mixed incontinence. The next type of incontinence can occur due to extraurethral causes as well. That will include fistulas, that is your vesico-vaginal fistulas or urethro-vaginal fistulas. And some other causes of urinary incontinence can include your ectopic vesicae or else your ectopic urethrae as well. Clear? Right. Now, let's see what is stress incontinence. So, stress incontinence means there is involuntary leakage of urine. Okay, there is involuntary leakage of urine that is happening during coughing, sneezing, laughing, etc. So, what all these three conditions are going to do? Yes, there is an increase in the intra-abdominal pressure. Okay, and no, stress incontinence is the most common type of incontinence as well. Clear? Right. Next one is urge incontinence. Here, there is involuntary leakage of urine with awareness accompanied, that is the awareness is there, okay, or it can be preceded by a voiding surge. It can be preceding by a voiding surge. Okay. Now, let's see about the mechanism of micturition in detail to understand the incontinence. So, let's discuss about the mechanism of micturition here so that you will know how incontinence is happening and how to manage incontinence as well. Okay. So, here when the bladder is getting filled, okay, there will be stimulation of the stretch receptors in the bladder that will be sending afferent impulses, and the nerve here is pelvic nerve. Okay, and this will be reaching the sacral segment of the spinal cord, and from there again efferent impulses will be given to the bladder again through the pelvic nerve. Okay, so there will be contraction of the detrusor muscles and relaxation of the internal sphincter. So, that is how the urine is going to come out. You have to imagine. So, if you consider this as the bladder, okay, imagine this as the bladder, and here you have your detrusor muscles. Okay, so what should happen? There should be contraction of the detrusor muscles and there should be relaxation of the internal sphincter. This should open up. So, then only what will happen? The urine, okay, will flow out. Can you imagine? Yes. And the next one is there will be flow. So, when this is happening, there will be flow of urine into the urethra and there will be stimulation of the stretch receptors again, and again the afferent impulses will be sent through the pelvic nerve that will be causing an inhibition of the pudendal nerve, so that there will be relaxation of the external sphincter. Not only the internal sphincter, the external sphincter should also get released, and the external sphincter relaxation is brought by the pudendal nerve, and that will be causing voiding of urine. Clear? So, once again we will come up. First, there is filling of the bladder, there will be stimulation of the stretch receptors, there will be afferent impulses which will be sent through the pelvic nerve, then it will be reaching the sacral segment of the spinal cord. Again, afferent impulses will be given through the pelvic nerve. There will be contraction of the detrusor muscles and relaxation of the internal sphincter. There will be flow of urine and stimulation of the stretch receptors, and again afferent impulses will be sent through the pelvic nerve. There will be inhibition of the pudendal nerve which will be causing relaxation of the external sphincter, and this will release and voiding of the urine. Clear? So, this mechanism is very important, right? Now, there will be no doubt, right? Now, let me talk about the continence. Okay, let's leave about incontinence. Let's first see what is important to maintain the continence of urine. Okay, so continence of urine is maintained by two main supports. Okay, one is your anatomical support, which will include your pubo-urethral ligament, orcus tendinous fascia, orcus tendinous fascia, and your levator ani muscles as well. Clear? And next one is sphincter support. Okay. So, this sphincter support is given by the urethral sphincter and there is another sphincter called ureterovaginal sphincter. Also, the sphincter as well as compressor urethrae. Clear? Yes. So, these are the anatomical support. And you also have to know that urinary epithelium is highly vascularized, especially in the premenopausal women, and this is also important for maintaining continence in them. Clear? Now, let's discuss in detail about stress urinary incontinence. So, it is stress urinary incontinence. Okay, let's see the pathophysiology. See here, there is loss of anatomical as well as sphincter support. Okay, so that is the main reason. So, stress, already we have seen what are the causes of stress. For example, if the woman is coughing, in a normal woman, what happens means, if there is any cause that is leading to increase in intra-abdominal pressure, it will be equally transmitted. Okay, this word is important. That will be equally transmitted to the bladder base as well as to the bladder neck. Okay, so imagine you have a bladder. Okay, when she is coughing, what happens? There will be increase in intra-abdominal pressure, and the pressure will be given equally to the bladder base as well as to the bladder neck. Clear? So, when this is compressing, this is also going to compress. That means urine leakage is not going to happen. Clear? Right. Now, let's see in women who have lost this anatomical support. Okay, in women who have lost this anatomical or sphincter support. Okay, is not present, then what happens? There is hypermobility. There is hypermobility of urethra, and this will cause to the loss of urethro-vaginal angle. So, the urethra is not retained in position. This will lead to a condition where urethra is not retained in position, and that will lead to incontinence. Yes? Understood? Right. Now, let's talk about the risk factors. So, the risk factors of urinary incontinence, especially stress urinary incontinence, include age, obesity, multiparity, vaginal birth. Why vaginal birth? Because there will be injury to the pelvic muscles. If she had a forceps delivery or there was prolonged labor, she has attained her menopause, there is a history of smoking, she is already affected with connective tissue disorders, she is a known case of COPD and chronic constipation. Okay, so these are the causes which will be leading to increase in the stress, and that will lead to stress urinary incontinence. Okay, right. Now, there are also types of stress urinary incontinence you have to know. So, the types of stress urinary incontinence, that is SUI, there are 3 types. Okay, so type 1, where there is loss of posterior urethro-vaginal angle. Type 2, where you have the loss of posterior UV angle, plus there is C1, hypermobility of the urethra, and then type 3, where there is intrinsic sphincter deficiency. Okay, there is intrinsic sphincter deficiency. Clear? Right. Now, let's discuss about the various investigations you will offer for women with stress urinary incontinence. So, investigations include, number 1, you have to give them urodynamic study that will constitute uroflowmetry. Okay, the normal flow rate, normal urine flow rate is 15 to 25 milliliter per second. So, this excludes obstruction. Any obstruction should not be there. If that is there means, if no obstruction is there means, repeating. So, if there is no obstruction means, it will be flowing at a rate of 15 to 25 milliliter per second. Okay. Next option, you will give them a cytometry. Okay, cytometry is a process. Repeating. Cytometry is an investigation to measure the pressure inside the bladder. Okay. So, the normal intravesical pressure is around 0 to 15 centimeter water. Okay. And here you have to know one important concept. The first voiding sensation comes when the bladder gets filled with 150 to 200 ml of urine. Actually, the capacity of the bladder is about 400 to 600 ml, and then residual urine usually should be less than 50 ml. Clear? Right. Now, let's also discuss about uretrocystometry. Okay. So, that is uretrocystometry. Okay. So, that is to measure the urethral pressure. Okay. So, normal urethral pressure is approximately 40 centimeter of water, and less than 20 centimeter of water will lead to incontinence. Clear? Now, let's also discuss about the other investigations you can offer. So, other investigations which you can offer them include urine analysis, and culture. You should offer even blood sugar levels, because you have to rule out diabetic nephropathy. Then you have to offer them intravenous pyelography, cystoscopy, just like endoscopy to visualize the bladder. Then you can even offer them a methylene blue swab test, urethroscopy, a micturition cystourethropy. Okay. And then you can offer them a MRI and neurophysiological studies as well. Okay. So, this will help you in finding if there is any defect in the pelvic floor muscles. Clear? Now, let's discuss about the management of stress urinary incontinence. Okay. So, management, first we have to give them a conservative management. That is very important. Okay. So, first type of management is conservative management. Yes. What do you think? Very good. We can offer them Kegel exercise, right? So, Kegel exercise, which is a pelvic floor exercise, this can be offered, and this can be offered for a period of 4 to 6 months, especially if the woman is young or frail old women and in postpartum period. Okay. So, this time you will offer Kegel's exercise. And the next type of management is medical management, where you will give drugs, especially in the postmenopausal women. You will offer them estrogen local applications. Clear? And the third type is surgical treatment, where the principle of the surgery is to elevate and restore the bladder neck and as well as the proximal urethra. Repeating. The principle of doing surgical management is to elevate and restore the bladder neck as well as the proximal urethra. Clear? So, we have some vaginal surgeries for stress urinary incontinence. The vaginal surgeries will include, repeating, the routes of doing, repeating, there are so many methods of doing surgery for stress urinary incontinence. One is doing through the vaginal route, where you can offer them Kedley's cysto-urethroplasty. Okay. So, this is nothing but doing anterior colporrhaphy with plication of bladder neck. Clear? And then the next one is you can do some retropubic colposuspension procedures, and the surgery name is Marshall-Marchetti Kranz operation. Okay, Marshall-Marchetti Kranz operation. So, here there is suturing of the periurethral tissues to the bladder neck, okay, and then to the periosteum of the back of pubic symphysis as well. Okay. But nowadays it is not performed because there can be complications as it is involving pubic symphysis. Osteitis of pubic symphysis can occur. Okay. So, this is not nowadays done. Repeating. So, this is not done nowadays. Okay. We have some midurethral sling procedures that can be TVT or TOT, that is transvaginal tape or transobturator tape. So, this is usually an outpatient procedure and this carries a success rate of 88 to 90%, right? So, presently the sling operations are performed by placing a sling that is made up of polypropylene mesh tape, okay, around the mid-urethra that will be given through a transvaginal position, and this will helping in lifting the urethra to bring back it to a normal position. Can you understand? So, that will be giving a pressure on urethra. Can you understand? So, we will be using a sling. The sling is nothing but a polypropylene mesh tape. We will be using the mesh tape to encircle the mid-urethra and give a pressure on the urethra. That is it. Okay, in simple words. Okay, fine. Now, so it is usually performed in cases where there is a failed surgery or internal sphincter dysfunction, or where there is mobile urethra as well. Clear? Now let's discuss about the two procedures separately. Okay, first one is transvaginal tape method. Now this method is a retropubic method. Here a small incision, okay, small incision is usually made, okay, that will be a vertical incision which will be made on the mid urethra, that is on its anterior vaginal wall. Okay, then a TVT needle will be introduced and it will be advanced through the space of reticulus to the anterior abdominal wall to allow the tape to be brought on either side in the suprapubic region to the stab incision what we have given. So, can you understand what it is? Just we are finding the urethra, and in the mid urethra on the anterior vaginal wall we are giving an incision. Then you are inserting the transoperator needle through this, okay, TVT, transvaginal tape repeating. So, can you understand this procedure? What is happening is you are finding the urethra, especially the mid urethra and the anterior vaginal wall, you are giving a vertical incision. Then you are inserting TVT needle which will be going through the space of reticulus and it will be passing through the anterior abdominal wall so that it will be covering on either side of the urethra and it will be coming to the suprapubic region as well as the through the incision back again. Clear? Right. So, after this, the tape, repeating. So, while doing this, hammock of tape is placed under urethra and the abdominal ends of the tape, okay, tape at the abdominal side or cut, okay. Then again you have to perform cystoscopy with the needle inside to check whether there is proper placement of the tape. Clear? Right. Next one is transobturator tape method. Okay, this can also be called as tension-free vaginal tape obturator. Okay, so here this TVT procedure is done similar, but the hammock of the needle is inserted into the midurethral canal and it is brought through the obturator canal. Okay, so here we saw it will be brought out through the space of reticulus. Okay, whereas here the hammock is brought out through the obturator canal. Okay, that is why it is called as transobturator tape. And then you have to know transobturator tape method is considered superior to transvaginal tape method because there is avoidance of space of Ritzius, and there is avoidance of osteitis as well as bladder injury. Okay, so these are the advantages. Okay, right. Now we have to know one thing, that is complication of mesh as well. So sometimes there can be erosion of the mesh into the bladder or urethra. Okay, so if that happens, 2% of the cases even may require removal of the tape, and 5% cases will have voiding problem again. Clear? Now, so this is all about stress urinary incontinence. We are going to discuss about urge incontinence in detail now. Okay. So let's discuss about urge incontinence. Repeating. So this is all about stress urinary incontinence. We are now going to discuss about urge incontinence. Okay. So urge incontinence. See, urge incontinence is nothing but detrusor overactivity. Okay, so it is detrusor overactivity. Okay, so there is motor urge incontinence. Okay, so when you do a ultrasound, it will show a bladder more than 6 millimeter thick, and you will also have some residual urine. Okay, and while doing urodynamic studies, you will be able to see involuntary contractions during the filling phase of the urodynamic study. Okay, during the filling phase. Clear? Now let's discuss what is overactive bladder. So overactive bladder is a term. It is considered as a syndrome as well, where there is increased urgency, frequency or nocturia, but this can present with or without urinary incontinence in the absence of urinary tract infection or any other obvious pathology. Okay, so that should be fun. You can keep it in mind. Okay, frequency, urgency and nocturia will be there. Okay, but urinary incontinence can be present or absent in any form, but definitely there is absence of this stress urinary tract infection as well as any other obvious pathology, right? Okay, now let's discuss what is sensory urge incontinence. So this can happen in cystitis, trigonitis or even foreign body. Okay, or we can also include a bladder stone and even a neoplasm that is present in the bladder. Clear? So what happens means sensory, repeating, now let's discuss about the management of urge incontinence. Okay, management of urge incontinence. This include lifestyle modification, First one is lifestyle modification. You should advise them to have an active lifestyle, weight reduction, and caffeine reduction as well. Okay, and also you can advise them to take bladder training exercises where they will be asked to hold urine in the bladder for a longer period of time. Okay, and this can be done by using a voiding diary. The patient is asked to void at a fixed time interval that is comfortable for long enough, and you can even give them estrogen cream that improves the incontinence in postmenopausal females, right? And next is medical therapy. So you can give them anticholinergics, anticholinergic drugs or musculotropic relaxants, and tricyclic antidepressants. Okay, so the drug is oxybutylene hydrochloride that is given at a dose of 5 to 10 milligram TDS, or you can give imipramine that is given at a dose of 50 to 100 milligram HS, that is at night, and tolterodine which is given at a dose of 2 milligram BD, duloxetine that can be given at a dose of 40 to 80 milligram BD, and finally dariphenazine that can be given at a dose of 5 to 15 milligram daily. Clear? Now you have to also know about DDAVP. Okay, so DDAVP, that is desmopressin, which is a synthetic antidiuretic hormone analog, and this is usually given as an intranasal dose of 20 to 40 microgram at night usually, and it will also treat nocturia and enuresis. Clear? Right. There is also another drug, that is marabagron. So this is a beta-3 adrenergic receptor agonist, and also you can give injection of botulinum toxin A into the detrusor muscle directly. Clear? So yeah, with this we are finishing urinary incontinence topic. Until we meet in the next topic, keep going, happy learning, and take care. Bye bye.